Hi everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Taylor Hayes, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the February 2025 issue dedicated to Cholesteatoma, guest edited by Dr. Samantha Ann and Michael Ho. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. Today I'm speaking with Drs. Samantha Anne and Dr. Michael Ho, who are the guest editors of the February 2025 issue of Clinics, which is on cholesteatoma. Dr. Anne is professor of otolaryngology, head and neck surgery, and medical director of the Pediatric Ear and Hearing Disorders section at the Head and Neck Institute at the Cleveland Clinic in Cleveland, Ohio, United States. Dr. Ho is professor and director of research at the Department of Otolaryngology, Head and Neck Surgery at Georgetown University Medical Center and medical director of the MGUH Cochlear Implant Program at MedStar Georgetown University Hospital in Washington, D.C., USA. Welcome, Samantha and Michael.
Hi.
Hi.
Thanks.
It is always a pleasure for me to record these podcasts, and prior to recording the podcasts, see how the guest editors work to put together these issues of Clinics so thoroughly and comprehensively. And even on a subject like cholesteatoma, as an otologist, I'm super familiar with this. It was wonderful to see the different thought processes that went into the way the two of you put this issue together, and the breadth of information covered in these 15 articles on cholesteatoma. So this issue of Clinics covers cholesteatoma in children and adults, and our listeners should take note that 3 of the 15 articles have accompanying video content that can be accessed online. Each of the articles can be purchased individually, or you can buy the entire issue as a whole, either online or as a hard copy. And every issue of Otolaryngologic Clinics of North America since 2017 has an accompanying podcast, which can be accessed free of charge wherever you get your podcasts. So let's get underway. I'm going to start with Dr. Anne. Dr. Anne goes by Samantha, and she goes by Sam, and she just goes by my friend who's a really great ear surgeon. So Sam, this edition starts with The Science of Cholesteatoma by Drs. Patel and Welch. What are the salient points regarding the science, and how can it affect future treatments in this mostly surgical disease?
Thanks, Sujana. The key thing to remember about this cholesteatoma, is that it's honestly the end stage disease of chronic ear infections, right? And with that comes the inflammatory responses and the infection and everything else that precedes that. So the science of cholesteatoma chapter really goes into what mechanisms and inflammatory signaling pathways are behind the scene and causing the chronic otitis media, which eventually leads to cholesteatoma. So this chapter is great in terms of pointing out some of the theoretical mechanisms that exist for cholesteatoma formation, starting with some of the histological data that we have, animal models that we have studied, and then it talks about some of the inflammatory signaling pathways. There's a couple of figures in there that were excellent that go into the different immunity factors and the cytokines and all the inflammatory signals that really play a role in the cholesteatoma formation. The idea is if we know the science behind the cholesteatoma formation, perhaps it can help us in the future in terms of targeting, pharmacological therapy for treatment of cholesteatoma. We all struggle with this as a surgical disease, and it's one of the most challenging things we do. And this chapter really breaks down the science that we know already. It also sets the stage for what we need to research further in finding a treatment for this.
Right. When I read this article, I was thinking this would be just wonderful if we get to the end stage, the patient needs surgery, we remove the cholesteatoma, and then we pack the ear with the anti-cholesteatoma stuff. And the anti-cholesteatoma stuff is the material that should be non-ototoxic and yet cholesteatoma toxic. And I think the only way to know that is to understand this degree of basic science, which I think is laid out really well. There's some really cool figures in this article, well worth looking at for all students of cholesteatoma. So as we move forward, Dr. Michael Ho goes by Michael, and also my friend who does amazing ear surgery. Doctors Maxwell and Hoff delineate how to evaluate the disease. So they talk about physical examination, audiometry, and imaging. We get it, but there are pearls in here. So can you talk to us about what are the salient details or what are the highlights of this, the way we should evaluate cholesteatoma correctly?
I think we all see this, and I think we're all have a high degree of suspicion when we examine an ear and see a patient. The authors really correctly point out that any form of granulation or polyps on exam should kind of cue us into the possibility of cholesteatoma, and we should be trying to prove that it's there until otherwise proven that it's not there, so to speak. I think it's very helpful to use ototopical drugs, like the authors suggest, as a way of suppressing the inflammatory response that the first chapter really talks about, and to improve our ability to examine the disease and to get more accurate radiologic diagnoses with both CT and MRI. And CT and MRI really play complementary roles. The CT really gives us a great look at kind of bony detail and bony erosion and structure of the middle ear and external ear, as well as the inner ear. And MRI, with the advent of some specialized diffusion-weighted imaging, really allows us to now surveil a disease. I think this chapter is really great because it provides some really nice images of different scenarios. And, being a good ear surgeon is part your training, but it's also the types of disease and the types of scenarios you see over time. So this is, seeing more makes you a better ear surgeon. And I think this chapter contributes to all of our joint education.
Yeah, my medical assistants, when I first start working with them, they're always quite concerned that I'm always making the films come up and always looking at them myself. But I think the only way we get better, as you said, is seeing more cases, seeing the images ourselves, and then talking with our radiology colleagues and say, I'm looking at this. Am I seeing something real or not? And I think, we better each other and we better patient care in that way. And I agree with you. I think that there's a wealth of information in this article. So now we've made the diagnosis. So let's talk about principles of management. There are many, many classification systems or staging systems that are used around the world. In the United States, we tend to use these staging systems or classification systems less robustly than in other areas. And obviously, intervention is individualized to the patient and the extent of disease at hand. But when we write articles or we present at conferences or we speak to each other, using systems that we all understand allows for optimal communication. So, Dr. Ane, Sam, can you give our listeners the take-home from the article by Drs. Angeli and Chang?
This chapter essentially is focusing on the fact that we use the information that we have to try to classify the severity of the disease. And then based on that, we can tailor the surgical decision making based on the staging that we have. The key one that they speak about, which I feel that is the most commonly used one is the EAONO JOS system. This one breaks it down into where stage 1 and 2 represents, local cholesteatoma with extension into the middle ear and mastoid. And then you have stage 3, which represents extracranial extension. So now we're talking about more extensive disease that includes the labyrinthine fistulas, the facial nerve weaknesses. And then stage 4 is the most severe disease, which involves intracranial extension and intracranial complications. So based on the staging of the disease, it can help you make decisions about the extent of surgery that's necessary. If the disease is limited to stage 1 and 2, canal wall up might be the best option. And if it's if it extends to the mastoid, then even the canal wall up can still be a great option. And at times, based on the severity, if it's stage 3, stage 4, we may lean on canal wall down. Some of these decision-making processes with these canal wall up, canal wall down mastoids, and other surgical techniques we're going to talk about a little bit later in this podcast. I won't go into it detail, but the staging system is supposed to set the stage for the decision making that we're going to make about the surgeries that we will do. And endoscopes, the authors briefly mention them and the utility of them in helping you dissect the disease in corners that we may not be able to see with microscopes. And they briefly touch on mastoid obliteration. Mastoid obliteration is showing promise in improving some of the hearing outcomes and also decreasing the recidivism rates and things like that. So we'll go into more detail on those topics a little bit later on, but this chapter is great in terms of setting the stage for figuring out how extensive the disease is and laying the framework for how we're going to make the surgical decisions later.
Thank you so much. And I think they point out that, these are never one and done. These patients all need long-term surveillance, both to look for recidivism, to make sure their hearing stays as good as it can. So if you're practicing in an area where it's difficult for patients to come back and see you, or it's a very mobile community, I think it really behooves the surgeon to ensure that the patient understands they need to see a ear, nose, and throat physician with these skills at various intervals in their life. And I think that's pointed out very nicely. So, I wrote in my preface to this issue that cholesteatoma isn't a cancer, even though it ends with oma and everybody's afraid when they come into the office, but it's just a growth of skin where it doesn't belong. However, the disease itself is not as benign as that description makes it out to be. So, Michael, Dr. Ho, Drs. Hura, Chu, and Santa Maria have a really nice article that looks at the complications that result from cholesteatoma. Can you elaborate on that?
The authors of the chapter really start off, base us in the idea that there's mucosal disease here. This stems from a chronic ear disease, and complications of the disease can be divided into intratemporal, extratemporal. The intratemporal involve hearing loss, obviously, facial nerve palsy, labyrinthine fistula, dysgeusia, labyrinthitis, ossificans, local bony invasion, sigmoid sinus complications, Petrous apicitis, and some other rare complications of acute otitis media. And, I think one of the nice things about this chapter is they show some really nice pictures of recognizing some of the endpoints of this disease, like a canal fistula, understanding what that looks like on radiologic exam and what that looks like on an exam of the ear during surgery, or even sometimes you see the after effects when you're looking at a patient in clinic who's had their cholesteatoma that was basically in one of the semicircular canals, and it's been exteriorized, so you can kind of see that. And learning to recognize that on your clinic exam is really important too. I think I always tell our trainees that they should draw what they see when they're looking at an ear in the clinic. And I think these pictures in this chapter are really helpful in beginning to have you begin to understand what that looks like. I think this chapter is really great, and I encourage the readers to really delve into this chapter if they get a chance.
Thank you. What do you think? You know, we're in a first world country in the United States. In this chapter, they talk about these intracranial or extratemporal bone complications. You know, we were taught, oh, this only happens in the third world, blah, blah. I actually don't think that that's true. I wonder if you can talk to us a bit about indexes of suspicion when somebody presents with an intradural or extradural abscess that's somewhere near the temporal bone, and how they should think about approaching that in terms of the best management option.
I think the chapter is very clear about getting a very thorough evaluation. Sometimes you cannot see normal landmarks on your own exam. So this is, I think, where imaging, both CT and MRI, really play a role. Sometimes the disease erodes structures that divide the ear from the brain. And I think a high index of suspicion for CSF and for the brain or encephaloceles existing in the setting of cholesteatoma are important. And in the setting of abscesses, which in the post-antibiotic era, we may see less than, say, they might see in a developing country or a country with maybe less antibiotics, but or disease that ends up being later stage when it's seen. We still see it, and I think it's very important to have a high index of suspicion when you see a patient that might not look like they are presenting how someone would normally present. The presence of facial palsy, the presence of dizziness, those are good indicators that something more invasive might be happening. Abscess, meningitis, high fevers, those are additional signs that you should be thinking that you might have a more invasive form of the disease.
So, you know, we started talking about management of complications, but let's go backwards and say, how do we manage these patients to begin with? So sometimes our favorite form of cholesteatoma is congenital cholesteatoma, because unlike what you two have been talking about, it's really not based in chronic otitis media. It's not based in inflammation. It's just sort of like a piece of epithelium that got stuck medially when the tympanic membrane was being developed. So there's a really nice article by Dr. Alfonso regarding congenital cholesteatoma. Sam, Dr. Ane, how is this disease process different, and what are the pearls? And sometimes these do look like pearls when you examine them, but what are the pearls that the listener should hear about?
Yeah, so this disease is, if you're going to get a cholesteatoma, this is the one you want. It tends to be less aggressive, and it starts off more contained in the anterior superior quadrant. It's less likely to be as invasive, and it can get to that point as the children get older, but starts off localized in the anterior superior quadrant. In this chapter, Dr. Alfonso, also goes into the staging system. Again, it helps define the surgical approach that we're going to use. Help define and also kind of predict and try to, again, help with our decision making in terms of the surgical approach. So the chapter goes into the POTSIC classification. This staging system is specific for congenital cholesteatoma, where disease 1 is confined to the single quadrant when it's in the anterior superior quadrant, for example. When it extends into multiple quadrants, but no ossicle or mastoid extension, that's called stage 2. Stage 3 is when it goes into multiple quadrants with ossicular involvement, but mastoid is still clean. And then stage 4 is when it's in multiple quadrants and extends into the mastoid. So this is a different staging system than we mentioned before, and it's specific to congenital cholesteatoma. And again, it can help us think about the surgical approach and the surgical extent of what we might need to do to take care of the disease. So this chapter is great in terms of identifying some of these common presentation and the staging system. And the chapter also goes into some of the advances in endoscopic surgery that can help with managing these cases, especially when they're in the early stages, with just transcanal endoscopic surgery without having to go behind through the mastoid for limited disease when it's not extending deep into the antrum.
Yeah, it's always nice when the pediatrician or the family doctor has picked up that nice little stage 1 congenital cholesteatoma, and you can manage it effectively, and the patient really is done with that problem. The next article, which is written by Doctors Fallon, Chi, and Remenschneider, talks about the management of acquired cholesteatoma, so not congenital cholesteatoma, but when the disease is limited to the middle ear and mastoid. So this begs the discussion of how you, as the surgeon, decide that pure endoscopic surgery may not be enough. So Sam, I'm going to kick it back to you and ask you if you can talk to us about the decision algorithms that should go through your mind as the surgeon of the best approach for acquired cholesteatoma that is relatively limited disease.
The first thing that authors, talk about in this chapter is first going through a checklist of things that you want to look for when you're trying to pick the surgical approach and the surgical extent that you want to do. So they have a nice table in there in terms of defining the location of the mass. Again, looking at the CT and figuring out if the mass is limited to the epitympanum or mesotympanum, and looking at the hidden areas that can sometimes hide disease. This can be seen on the CT scan, such as, disease in the facial recess, sinus tympani. The CT should also be used to look at the ossicles, whether they're eroded, and things like that. The table goes into other things that are important to define, and is there facial nerve dehiscence, tegment dehiscence, and also how pneumatized the mastoid is, and so forth. So based on those, the extent of the disease can help you determine the extent of the surgical approach that you would need. So this chapter to doing various types of mastoids, whether it's canal wall up or canal wall down, and also using reconstructive procedures such as mastoid obliteration when necessary. And sometimes, the authors also mention that sometimes the surgeon comfort can take a large part in the management, and there's no standardized best method of treatment. And if a surgeon is very comfortable with the use of endoscopes, then they can. And if they're able to get the disease by looking around the corners and comfortably manage these patients transcanal and able to accentuate the disease completely with endoscopes, then that can be the right approach.
Yeah, and I think this really confirms the idea that really you should have done the operation in your head. Maybe during the clinic visit, or certainly when you're looking at the CAT scan, you're executing in the operating room, but the plan and the, plan A, plan B, plan C is really mapped out, and surgeon comfort, I think, is really important. You had pointed out pneumatization of the mastoid. If it's not a big mastoid and you can take the canal wall down and leave them with essentially just a larger ear canal, you may save them a lot of heartache later on, as long as you know why you're doing the steps that you're doing. So I think this really lends to understanding the parts of the exam and the parts of the imaging that are the most important as you plan your surgery. So as we go forward, I'm going to ask Michael, Dr. Ho, let's talk about Petrous bone or medially invasive cholesteatoma. Thankfully, this is quite rare because it is really challenging to manage. There's a very nice article that you guys included by Doctors Adams, Masalak, Adunka, and Cosetti and it explains how to classify this anatomically and think about how to approach such cases. So, can you give us some highlights about these sort of much more challenging cases and often fraught with later complications?
This chapter's really, I think, key to that. They really go over how these aggressive cholesteatomas presented. They point out in Table 1 the Santa classification of Petrous temporal bone cholesteatoma, and there are different types, including supralabyrinthine, which is centered over the geniculate ganglion in the epitympanum, infralabyrinthine, which involve the infracochlear, infralabyrinthine, and hypotympanic air cells, the infralabyrinthine to apical that tracks medially towards the apex, and a massive or extensive cholesteatoma, which involves the aortic capsule and multiple compartments of the temporal bone. And there is an isolated apical, which is a cholesteatoma centered in the Petrous apex. But I think the value of this classification system is it gives you a way to think about the cholesteatoma and begin to organize management in your head and the anatomical structures that are going to be involved as you seek to rid the patient of this very aggressive disease. The authors did a very nice job of providing a figure showing the different tracks that are mentioned in the Santa classification system in Figure 2. And I think very key is their figure on kind of an algorithm for management depending on where the cholesteatoma is based on the Santa classification, as well as whether they have serviceable or non-serviceable hearing. The approaches, depending on where things are, can involve everything from a middle fossa approach to a subtotal petrosectomy, or a mastoid or translabyrinthine approach, depending on whether there's serviceable or non-serviceable hearing. So there are a lot of different approaches when the disease is more aggressive, which is very often. So the most common is that extensive or massive cholesteatoma. Often hearing is really not the concern here. It's preservation of the facial nerve, if that is possible at that point, and sometimes it's not. And sometimes really we're really trying to save the patient's life in this type of setting and minimize the complications like CSF leak and facial nerve function at that point.
Yeah, and I think you mentioned subtotal petrosectomy and blind sac closure. The article by Doctors Wand, Gubbles, and Brandt covers this. I think that both of you have highlighted the rationale for thoughtful preparation preoperatively. Can you talk to us about the 4 general principles, Michael, about doing a subtotal petrosectomy with blind sac closure of the ear canal correctly, so that, because now you've closed everything, right? So now you are absolutely relying on symptoms and imaging to know if this disease has come back. So can you talk to us a bit about that?
Yeah, so first, generally from the subtotal petrosectomy approach, you're trying to exonerate or remove all the diseased air cells. You're removing all the middle ear and external auditory canal skin or epithelium. You're obliterating the eustachian tube, and you're closing the ear canal. Now, the disadvantages here, like you just mentioned, are that you can no longer see, and that you are dependent upon periodic imaging, usually both CT and MRI. Particularly, we use, the authors mentioned, and several chapters mentioned, the use of diffusion-weighted imaging, particularly non-echoplanar imaging, diffusion-weighted imaging. They also talk about different techniques to obliterate the cavity or obliterate that space. The use of bone chips and bone pate, a temporalis muscle flap, a pulva flap, SCM. So there are a variety of ways to obliterate the cavity, and removing the mastoid tip, which is obviously part of removing the disease. Sometimes that's already done for you by the disease, but really that also helps collapse that space as well. In worst case scenarios, sometimes a flap is needed in these cases, and involving or engaging your head and neck colleagues is sometimes a very necessary endeavor.
Yeah, I think these operations are definitely not for the faint of heart. And if you haven't done one in a while and you're anticipating doing one, I would strongly recommend a trip to the temporal bone dissection lab and drill out a couple of bones. I have the great fortune that my father is an ear, nose, and throat surgeon and loves ear surgery in particular. And I remember as a junior attending, I had a lateral temporal bone resection to do for cancer. And that was going to happen on a Monday. Sunday morning, I showed up at my parents' apartment, had a great breakfast prepared by my mother. My dad and I went over to the temporal bone lab, dissected out the surgery I was going to do the next day for a couple hours, and then came back for lunch, and I felt totally prepared. So I think this is our passion and our avocation, and when you can do it like that, it's really it makes you much less timid and much more capable of doing a really good job for the patient at the time that they need it. I'm Sujana Chandrasekhar, consulting editor of Otolaryngologic Clinics of North America, and today I'm interviewing Dr. Samantha Ane from Cleveland Clinic, Ohio, and Dr. Michael Ho from Georgetown University in Washington, D.C. They are the guest editors of the February 2025 issue of Clinics, which is on cholesteatoma. You can access all the issues and articles in every issue of Clinics at www.oto.theclinics.com or in your institutional or hopefully personal library. And you can access a free podcast per issue since 2017 on that website or wherever you get your podcasts. Please let your friends know as well. So we're going to move on. And Samantha, you already talked a bit about endoscopes. And I'm glad that you included this article by Drs. James and Fina on endoscopic ear surgery for cholesteatoma. The authors have provided a very nice illustrative video that accompanies the article online, and there are some lovely images in the article. So, Sam, what are the important considerations when somebody's first starting to use endoscopic approaches for cholesteatoma? And you had mentioned this briefly, but can you expound upon the areas where you think the endoscope is really very helpful?
Yeah, this chapter, I love this chapter because it really goes into some of the technology that we can now use to help us in battling cholesteatoma. The endoscopic surgery, this chapter focuses on some of the basics on how to get started, and also some advice on how to make it safe for the surgeon to start with the endoscopes. And then it goes into when it's the most appropriate to use them. For example, endoscopic surgery is perfect when it's disease is limited to the tympanic cavity. But then, however, if the disease is extending a little bit more into the attic and antrum, sometimes the endoscopes can be used, but it would require bone removal and drilling or curetting some of that bone. So the comfort level with using endoscopes will sometimes dictate what you can do with them. And then safe, endoscopic surgery does require, surgeons to start with the basics and then build from that. Trying to attempt a OCR as an initial surgery is probably not the right move. In cholesteatoma surgery, that's around the oval window and with the dehiscent nerve might not be the best place to start practicing with endoscopes. So the authors go into how to set up the room and the right tools, and also how to be ergonomically correct in terms of, placing the screen at the right eye level, how the height of the chair should be adjusted, so your thighs are parallel, and really just stabilizing your arms as well in terms of setting yourself up for success. The authors go into some of the techniques and some of the tools that we use specifically when we're doing endoscopic surgery.
It's a great way to look at endoscopic ear surgery. We do have a full issue of clinics on endoscopic ear surgery, but certainly this is a very nice, very complete primer. Let's talk very briefly about a little bit more open surgery. There's an article by Doctors Arambula, McGee, Doyle, and Mowry, who wrote about mastoidectomy. And here again, they provided video content, which is extremely helpful and interesting to watch, both for the novice and the advanced learner. So Michael, Dr. Ho, can you help us understand the Bondi modified radical mastoidectomy in particular, how you might do it, when and why you do it, and what the expected outcomes can be?
The Bondi modified radical mastoidectomy really refers to a canal wall down mastoidectomy where you preserve the mesotympanum or the middle ear, so you're not entering the middle ear, and it's commonly done in cases where you have an only hearing ear or a better hearing ear with a cholesteatoma that you can exteriorize. And I think modified radical mastoidectomy, as the authors point out, has come to mean a canal wall down with sometimes some entry into the middle ear, but they really set forth and said, we're going to refer to canal wall downs that involve addressing the middle ear as well, and we're going to return to the older originally intended literature that the Bondi modified radical mastoidectomy leaves the middle ear alone or preserves that space and doesn't intervene there. The expected outcomes here are that you can exteriorize the disease and keep hearing the way it is, so to speak. In terms of retrograde mastoidectomy, Sujana, you mentioned earlier about sclerotic or small mastoid cavities, and retrograde mastoidectomies are really great in this setting because often, like you said, you can just have a larger ear canal. The use of endoscopes has helped us in these settings to be able to be more confident that we've removed disease in these settings, and really getting behind the cholesteatoma on a retrograde mastoidectomy and pushing and dissecting that forward, I think are very important parts of that.
Yeah, I was actually thinking about this article when I was doing a retrograde mastoidectomy yesterday. And I was like, yeah, it's a good thing I read this article in preparation for this podcast. Let's go on to bigger approaches. So you guys included an article by Doctors Ginny, Kalmanson, Noonan, and Nassiri, which details techniques of radical and canal wall down mastoidectomy. And again, we're very grateful to those authors. They provided some really wonderful video content to accompany their article. So Sam, Dr. Ane, when do you say that's it? You got to take down the canal, you got to make this a big operation. And what should the surgeon be aware of in terms of specific surgical rules that make for a better outcome, and how to counsel patients when you are thinking about doing this type of operation?
Yeah, first thing to remember, is that there's different levels of mastoidectomy. For example, the radical mastoidectomy that we talk about is we just exteriorize everything. The mastoid middle ear, external ear canal, you remove the tympanic membrane, the ossicles, and everything is removed and there's no reconstruction. From there, you can do a modified radical, which Michael talked about, where you save the tympanic membrane and the ossicles. And then there's a canal wall down that we are talking about now, where you exteriorize the mastoid, the middle ear, but you're reconstructing the tympanic membrane and possibly doing the circular chain reconstruction. So we have different gradients about how much of a mastoidectomy you are actually doing. Now, with the decision to move forward, really depends on a few factors. And the first thing is trying to realize, is there specific anatomy features that would predispose you to move forward with a more aggressive surgery, for example. Looking, and thinking about, for example, indications for canal wall down mastoidectomy. So you think about these patients when there's large fistulas or, like poor access to the disease is difficult to visualize with just the canal wall down. And, even then you don't necessarily have to do a canal wall down mastoidectomy, but, and you can remove matrix off the fistula without, repair it and safely. So you don't have to be obligated to do a canal wall down mastoidectomy, but that should be in the toolbox if the surgeon needs it. And then thinking about other things that might make you want to just proceed with a canal wall down is something that you mentioned earlier. What if there's a super sclerotic mastoid or a very anterior sigmoid sinus, and that limits your access to a traditional mastoid? That could be one reason. And sometimes people just want one surgery and not have to go back. And especially in setting of extensive disease or patients that are coming from long distances and don't have the capability to keep coming back for visits, they may want just one surgery and be done with it. So there are absolutely reasons that canal wall down might be the right answer. And there are times when canal wall up is a great option. And this, sometimes you can reconstruct the ear canal or obliterate the mastoid in conjunction with the canal wall down. So having all these surgical options in the toolbox is great when you have, all these options in terms of managing the disease and whatever presents for you in the middle of the case.
Right. So when I started my journey in otology, the big debate was canal wall up versus canal wall down. And I think that still is debated, but now we have the monkey wrench of endoscopic approaches. We have the diffusion weighted MRI images that can help us. We have the reconstruction. We have the various materials that can be used even in a sort of a messy mastoid. It doesn't have to be pristine for us to reconstruct. The two of you included an article written by Drs. Tan, Schauwecker, Perkins, and Lee, looking at outcomes on various surgical approaches. I will direct our listeners to read this article, particularly if you are being systematic about your cases, which you should be, and engaging in clinical research and looking back at how well or how poorly you may have done over the years. They talk about various quality of life measures, including COMQ12, CED, ZCMEI24, and COMOT15, which are various quality of life measures that really look systematically at how the patients are doing over time with this care. So I'm going to move forward and talk a little bit about hearing. So now we've got this patient who's had their surgeries and they're free of cholesteatoma. Their ear actually looks pretty good, but now they've got some degree and type of hearing loss. It's very interesting because the three of us on this call and Dr. Pittman wrote an article on hearing restoration after cholesteatoma surgery. So Sam, let's start with a very quick primer for our listeners on bone conduction devices.
So traditionally, we have resorted to using percutaneous implants, but we have now a couple of devices that have come on board in terms of using transcutaneous. Bone Bridge, Ossia, are two of the latest in the bone conduction device technology. And there's even newer ones since this chapter's been written. So there are new options that are coming across, these days. There's always the Adhere and SoundBridge. So there's multiple options in terms of treating these patients when they have more than just a mild to moderate conductive hearing loss. Sometimes even the moderate conductive losses may do well with these bone anchored devices.
Yeah, thank you. And I think that's goes to a pediatric age group as well, which is very interesting. So certainly an option you and your audiologist should be familiar with. Speaking of audiologists, we are part of the hearing healthcare team. And the technology in audiology seems to change all the time. So Michael, Dr. Ho, people ask us a lot as surgeons about advanced hearing solutions. Can you sort of tell me how you would counsel a patient, knowing that the expert is actually the audiologist that you're sending them to, but they want some foreknowledge before they get there?
I think this chapter rightly points out kind of these advanced hearing solutions, which some are based in Bluetooth technology, and include ways to lower the signal to noise ratio to make it easier for these patients to hear. And these include FM modulation and hearing loops, and also given our pervasive use of Bluetooth, direct transmission of things like phone conversations to a hearing aid or the TV, or podcasts and so forth. So listening, and this is where our audiologist as a vital part of our team can really contribute and really provide that expertise. But this is kind of the overview there.
So you guys included an article by Ibrahim, Setun, Kazahaya, and Stukin on complications, and we do our best to avoid them. And there are some lists in that article of the different complications. I'm just going to remind our listeners that facial nerve monitoring is often considered an integral part of mastoidectomy surgery. There have been some issues with facial nerve monitoring in the United States and around the world recently. So I'm just going to take chair prerogative. When I was president of the American Otological Society, we hosted a webinar that featured Doctors Jack Cartouche, Craig Buckman, David Cayley, Nancy Young, and was moderated by me on facial nerve monitoring. It's free to anybody who wants to watch it. You can find it on YouTube, or you can find it on the American Otological Society webpage. And it's accompanied with a lot of information provided by Dr. Cartouche. So as you are monitoring, please do take advantage of that material because you will be a safer monitor and your patients will do better. So I think the last thing I want to touch on as we talk about cholesteatoma is recidivism, because I feel like we have not yet found the magic stuff that we put into the mastoid after cholesteatoma surgery to make it never come back. And we do have really a high recidivism rate. Dr. Simon Parisier used to say, all you need to have a successful practice in otology is 10 kids with cholesteatoma, because you'd be busy the rest of your life. And I hope we're a little bit better than that. Maybe we need 20 kids now, I don't know. But, pediatric cholesteatoma has a higher rate of recurrence or recidivistic disease, which means that the disease was there even though you thought you had removed everything. But adult cholesteatoma is not too far behind. So Sam, Dr. Ane, what do we do to make this better? It's so nice to make people well.
Yeah, Sujana, this is, I live this every day. These children the disease is so aggressive. And you're absolutely right. The rates of recurrence in, residual disease is up to 60% in these cases. And the recurrence, and telling the parents 50% chance likely you're going to need a second surgery, even after they're or another surgery after they're completely cured. It's a gift that keeps giving, unfortunately. A couple of things that this chapter, talks about is maybe potentially being able to avoid surgery in certain cases by using imaging, for example. When you're confident in the fact that you got the disease and you want to have surveillance of the patient, one option, for example, is to use diffusion-weighted MRI. And these MRIs have now got sensitive enough that they can pick up cholesteatoma as small as 3 millimeters. So this is one tool that has helped us in these pediatric patients, especially, and I know it's been used in adults as well, is when there's fairly good confidence that the disease was completely removed, the MRI can help do the surveillance instead of doing this obligated second looks. Nevertheless, this is a very difficult disease that continues to make us struggle. A lot to, still figure out in terms of how to best manage these patients.
Yeah, I think this article by Cooperman, Wong, Penghua, and Aliano really talks about that. I think kudos to our friends and our colleagues in radiology, because they have really surpassed our expectations in terms of reduction of radiation dose for CT images, which is of quite concern in children who keep having to get images, and of this, as you said, really beautiful images that we can find on MRI. They can help us say, hey, we don't have to go back in this year, or we do have to go back in this year. And I think that's really very helpful. I want to congratulate both of you, Dr. Samantha Ane and Dr. Michael Ho, for putting together just a really thorough, useful, user-friendly issue of Otolaryngologic Clinics of North America. This is the February 2025 issue, and it's on cholesteatoma. I've had a really lovely time talking to you about something that I enjoy thinking about, and that I have become smarter at as a result of reading your issue. Dr. Ane is professor of otolaryngology, head and neck surgery, and medical director of the pediatric ear and hearing disorders at the Head and Neck Institute at the Cleveland Clinic in Cleveland, Ohio, USA. Dr. Ho is professor and director of research at the Department of Otolaryngology, Head and Neck Surgery at Georgetown University Medical Center and medical director of the MedStar Georgetown University Hospital Cochlear Implant Program in Washington, D.C., USA. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and I practice in New York City and in New Jersey. You can access all issues and articles in every issue of Clinics at www.oto.theclinics.com or in your institutional or personal library. And you can access a free podcast per issue since 2017 at that website or wherever you get your podcasts. I really want to thank you, Sam and Michael, for your excellent work, for agreeing to guest edit, for putting together such an interesting group of authors and articles, and for spending your time and energy for recording this podcast, which reaches across the world. So thank you guys so much for all that you do for patient care, both individually and in communities like this.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on cholesteatoma, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on X and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.